All right. So, hi, good evening, everyone. Hi. So, good evening, everyone. Abhilash is there. Yeah. So, I can see few of you getting live. So, I'll just wait for a few seconds before everybody can join in. And we start with this series of DBMCI where we are going to discuss about the most important topics which are often asked in your INICET exam, right? So, hi, good evening to all. Abhilash, Megha, Krishna, Hemant, Aditya. Okay. So, yeah, I'll just wait for a while, Nandesh, and so that everybody can join in. And then we start with this topics, all the topics of the orthopedics, which are very, very important for your INICET exam. Okay, so I'll just show you one list before I start with the topics. And then very quickly, we are going to revise all the important images, all the important things which are required for your INICET examination. All right. Okay, so all right. So I think we can start. Audio, video, both are fine. If some of you can confirm, if it is okay, then I think we should start with this. Yeah, good evening, everyone. Nitin, all good, all good. Thank you so much. All right, so thank you, Harshi, for the confirmation. So let's start with this now. All right, guys. So in front of you, I'm just opening up this table here. See, these are some of the topics which are frequently asked in your INICET examination, right? The reason why they are asked so often is very simple, that these are most of the common, patients that we see in our orthopedics OPD, or maybe the orthopedic emergency or the wards here. So if you talk about the very basics of the bones, in the recent years, what we have seen is that you have got questions from the growth plates where the trauma happens, where all the other things are happening. So that is why on the top I have kept it as the structure of the bone as well as the structure of the growth plate and its relevance, that what are the different zones of the growth plate, and what all they are into, what all they are up to, like growth plate injuries may happen where, or the genetic disorders may happen where, the metabolic disorders may happen where, like that. And from the mineralization disorders, from the metabolic disorders, we have rickets, malacia, rickets versus scurvy, osteoporosis, trauma. We have got open fracture classifications, the different types of fixators we have, and basic orthopedic implants we should know, shoulder dislocation, supracondylar, compartment syndrome, and so on. So this is a list of the topic which is very frequently asked from the trauma section as well as from all other sections like the nerves, bone tumors, infections, pediatric disorders, and so on, right? So this is just what I'm going to share with all of you now. Okay, so just give me one moment and we are going to start with this. So, all right. So let me just start with this. Yeah. So now when you just look at these, okay, now it is fine. So now I hope the audio video relay is going fine, and let's start with this now. Let's start with the session part now. See, all the topics I'm just going to cover up, telling you all the relevance of all these topics one by one. So very first topic we have is the structure of the bone and its relevance. See how the structure of the bone actually looks like. See, when you look at the structure of the bone, this is a very first slide I want you to focus upon. Okay, when you look at a bone, how does a bone looks like? You know, the end of the bone basically is called as what? The epiphyseal area, right? Epi then have the shaded area which we call as the growth plate. Then we have the metaphyseal area and the diaphyseal area. That's how any of the long bone will look like, right? In the structure of the bone, we should always remember that the bone is being protected by a layer, and that layer is called as the periosteum here. This one in the green is the periosteum, which I'm putting again here. This is periosteum, and this periosteum, it merges with the capsule of a particular joint. So this layer here is the capsule of that particular joint, right? So when you look at my periosteum of ulna, it is all continuous, all continuous, all continuous, and then it merges with the capsule of the elbow area, and then continues as the shaft of the periosteum continues on shaft of humerus. All right. Now, when you talk about periosteum, what is the role of periosteum? You all know that the inner layer of the periosteum, it is the cambium layer. It has got the osteogenic potential. So whenever the bone is getting affected by any of the pathology, whether it is trauma, tumors, infection, or so on, the periosteal responses are seen, right? Sunburst appearance, Codman's triangle, the onion peel appearance, like that. So from where all that the responses are coming, it is all coming from this periosteum's cambium layer, right? That is one. And second, when you talk about the growth plate, when we talk about this growth plate, you can very well appreciate that this internal part of the growth plate here, it is divided into 5 zones. These are 5 microscopic zones we have, right? You start from the epiphyseal side and we reach out to the metaphyseal side. The zones we have in the growth plate, they are starting from the resting cartilage. Number one, you can see here. Okay, that is the first one, is the zone of resting cartilage. Then second one, we have the zone of proliferation. Third one is the zone of hypertrophy, mineralization, and ossification. Okay, now you know very well that the screen looking small. Okay, I don't know, Rishabh, if you can please see the comment and do the needful. Okay, now see, when you look at the zones of the growth plate, the very first layer is the resting cartilage, which is also called as the germinal layer, right? The germinal layer we have the proliferation layer. With the cells proliferate, they are associated with the disorders of dwarfism or being the gigantism, a person getting taller or a person remaining short. It depends on zone number 2. Hypertrophy, this was your INICET question in the recent session, that which is the zone of the growth plate which is most commonly involved in trauma. So most commonly involved in trauma is always the hypertrophy, right? Zone of mineralization, where we see the metabolic disorder rickets happening, is the zone of mineralization, and the zone of ossification is the scurvy, the last one. So 5 zones of the growth plate, and they are affected in different kind of disorders, starting from hypertrophy, mineralization, ossification, where the bone will be properly formed, right? So hypertrophy is the zone from where we get trauma. Most often rickets, it affects the zone of mineralization. This zone of mineralization is not a separate layer. It is the lower part of hypertrophy only, right? And the last one, we have the zone of ossification. Now this is where the properly formed bone is seen. Okay, so bony formation starting from zone 1 to zone 5. That is the number one, the first thing you should know, the relevance of the growth plate, the relevance of the periosteum and its cambium layer, right? This cambium layer is the one which is helping you out in all the ways, protecting the bone from trauma, callus, and bone tumors, and so on, right? The very first thing. Okay, now from the metabolic disorders, the very first thing, now is the font size okay? Is that okay with everyone now? Okay. Now, second one I want to understand is the metabolic disorders, the disorders of mineralization and others. Now, see, look at this, table in front of you. Look at this chart in front of you. It is telling you how the bone is formed. See, bone is made up of 3 components, right? Primarily 3 components are there. Bone is cell, bone is the protein, and bone has the mineralization. So bone has got these 3 components, and each of the 3 components of the bone, they are linked to two disorders, right? Okay, they are like two disorders. Now, if you talk about the disorders of the cell, always remember that in the cell category, the culprit is always a osteoclast, right? The culprit is always going to be the osteoclast. Cellular disorders, whenever there is a hyperfunctionality of the osteoclast, the disorder the bone suffers from is Paget's. You remember that? And the defective osteoclast, it has to be petrosis. So clast working too much, Paget's not working at all, petrosis. Similarly, the major protein of the bone is the type 1 procollagen, and this collagen is the one which is present everywhere, the bone, the sclera, the teeth, the blood vessels, skin, everywhere. Whenever there is a genetic defect of the collagen, the disorder patient suffers from is osteogenesis imperfecta, right? And whenever there is a nutritional deficiency of the same component, the type 1 collagen, the disorder patient suffers from is scurvy. So OI and scurvy. So type 1 procollagen nutritional problem, scurvy, and the genetic disorder is osteogenesis imperfecta. Okay. Number 3, the mineral component. The minerals making the bone, the calcium, the phosphorus, and for their transportation, for their resorption, for their regulation, what we need is vitamin D. So whenever the bones have a deficiency of the calcium, phosphorus, vitamin D, in a child, we call it the disorder Rickets, and in the adults, it has to be malacia. So 6 disorders, 2 of each category, right? 2 of each category, 2 of mineral, 2 of the protein, and 2 of the cellular part. Now, anytime any question is asked to you in your INICET exam, they often give you this kind of question, that serum mineralization is altered in what all disorders? So serum mineralization is altered basically only in two disorders. You have to remember, rickets and malacia. If there is a question in your exam, whether it is about osteogenesis imperfecta or scurvy or Paget's or petrosis or even osteoporosis, then serum mineralization usually stays normal in them, right? It will be low only in the disorders of mineralization. All right. Now see, next one. Next, I want you to understand the concept of osteoporosis. See, osteoporosis, every single line for INICET is important. The most commonest trouble that we see in the orthopedic OPD, the elder patient, is osteoporosis. And that is why most commonest questions you are going to see are from osteoporosis only. Okay. Now see, osteoporosis, what you all have to remember, that what exactly is osteoporosis? Of all the three components of the bone, the cell, the protein and the mineral, all the three, they get reduced in the bone, and that too in the proportionate manner. That is the most important thing you have to remember, right? That is a proportionate decrease in all the constituents of the bone. Okay. And when they ask about osteoporosis, you should always know that most commonest site affected in osteoporosis, what are those? Vertebra, neck of the femur and the distal end of the radius. And what is common in all the three? Vertebra, neck of femur and the distal end of radius. What is common? That all of these three sites, they are cancellous bones, right? They are all cancellous areas, and that is the commonest site to get involved in osteoporosis. Now whenever there is a patient of osteoporosis having a backache, having the troubles around the groin area or the distal end of radius area, the soft areas, what can be the issues they might be coming to you with? If it is usually a non-traumatic presentation, they come to us with the codfish spine appearance, right? They come to you with what? Codfish spine appearance. And if it is a traumatic case, they usually come to us with a compression fractures. How is that seen? See, codfish spine appearance is something like this that you can see on the screen, right? Every vertebra is getting a compression, the biconcavity in between the intervertebral disc spaces, right? The disc is there, and all the vertebrae, they show you the compression effect like that. See this? So this is the compression effect into the vertebra, making the design of a fish in between the vertebral bodies, right? This is called as what? The codfish spine appearance. This is called as the codfish spine appearance. And if it is a trauma case, then trauma will not be a very significant one. It's a very, very mild form of trauma, right? Person tries to tell you, I was going down the stairs, missed a step, had a twist of the ankle, have a twist of the foot area, and groin is stretched. Groin has got a jerk, back has got a jerk. Like that, the patient usually comes to you, right? So traumatic, it is a localized finding of the compression fractures. Non-traumatic, it will be usually a codfish spine appearance, right? In osteoporosis, how do you diagnose a case of osteoporosis? It is done by the usage of DEXA scan, right? It is done by the usage of DEXA scan, which test for the T scores. So T scores anytime going worse than, decrease than 2.5 is called as the osteoporosis, right? Anything that better than 2.5 standard deviation is a fine one, right? But when it is going worse than 2.5, we call it osteoporosis. Okay. This DEXA scan, please remember, it is routinely recommended in every female above the age of 65 and in every male above the age of 70. This is routinely to be done. Okay. And what exactly is T score? It is a comparison of the bone mineral density of our patient with a healthy young individual of same gender. With a healthy young individual of same gender, right? So this is, yeah, so this is what BMD is. This is what T score is, comparison of the bone mineral density of our patient with the healthy young individual of same gender, right? When you have to treat osteoporosis, please do remember that the first line drug, the preferred first line drug is always and always a bisphosphonate, right? It is always and always a bisphosphonate. Please remember that, right? That would be always a bisphosphonate. We have different types of bisphosphonates like alendronate, zoledronate, ibandronate, risdronate, out of which a little odd one out is zoledronic. It is a long-acting one, and it is given IV once in a year, right? But bisphosphonates, you remember, they come with a complication that they may increase the chances of fractures, right? Osteonecrosis of the jaw can also happen, but that usually happens in only those individuals who are taking some dental treatment while taking bisphosphonates, right? So bisphosphonates can increase the risk of fractures in the bones. Second drug here, decreasing the resorption of the bone, that is decreasing the clastic activity, is calcitonin. Okay, and then estrogen and SERMs are also there, the hormonal preparations we have. On the other hand, we have to also give the drug which is going to increase the formation of the bone, and that starts with teriparatides, calcium, and calcitriol, that is vitamin D. Okay, always remember the normal requirement of calcium per day in our body is 800 to 1000 milligram, that is 1 gram. Okay, the dosage required per day 800 to 1000 milligram, and when you give the supplements, the requirement may increase up to 1200 or 1300 depending upon the age. If it is a adolescent age group, there might be more requirement. If it is elderly age group, again it might be more requirement. So 800 to 1000 milligram is the usual dosage required, right? Denosumab, it blocks the rank ligands, and strontium renylate, it has got a dual action. So for osteoporosis, every single line you should know, because this is the most commonest patient seen in orthopedic OPD in the elderly age group coming to you with the pathological fractures, right? That is osteoporosis. Second most important topic from here, it is going to be your rickets and malacia. The rickets being the most important one, and from where we usually see the MCQs. Now see, in the rickets, what all you have to understand, in the very recent exam, we had a question about the deformities of the leg. See, when you talk about rickets, you should always remember that whenever we talk about rickets, most commonest presentation of the ricketic patient is usually the deformity of the legs, right? It is usually the deformity of legs. And in deformity of the legs, child can have both the deformities. They can have the varus deformities, that can have genu varus, or they can have genu valgus, right? Genu varus is usually seen in the smaller kids, infants, because this is how the child is born. And the valgus is seen in some little grown up kind of kids who are more than usually 4 years, 5 years, 6 years, 7 years of age, right? This time we had a question that where do we see the wind swept deformity of the legs? The question was about the wind swept deformity of legs. Where do we see the wind swept deformity of the legs? The wind swept deformity of the legs. What is that wind swept deformity? The wind swept deformity of the legs means, like this image, if you can see, the child is having valgus in the right leg and varus in the left leg. Valgus in the right leg. So both the legs are bent to one side only, as if the wind is sweeping the legs, right? So, rickets can happen because of all the three reasons. It can be a deficiency of calcium or phosphorus or vitamin D. So it can happen because of all the three reasons, the calcium, phosphorus, and vitamin D. Remember this, that most often this kind of wind swept we are talking about, this kind of wind swept that we are talking about, they usually happen with the hypophosphatemic kind of rickets, right? When there is a phosphorus having a trouble, and that is usually related to what? That is usually related to the renal osteodystrophies. Okay, so wind swept deformities, annotations and the writing is lagging. Okay, I'm not sure. Let me just connect with Rishabh, is the person managing it. Let me just give him a call. Okay, let me just give him a call. Let me ask him if there is a trouble. I'm not very sure. Let me just give him a call. So wind swept deformity was the recent year question, right? So recent session, how you should know that calcium, phosphorus, or vitamin D, all the three can create the deficiency of mineralization, and that is what we are calling as simply the cases of rickets or the malacia in the adults. We have the mineralization problem. So wind swept usually is related to hypophosphatemic rickets, right? Now whenever we treat the cases of rickets, you should know the basic parameter, basic abnormality. Either it can be a deficiency of calcium or the phosphorus or the vitamin D. Now whenever whatever is deficient, whether it is low of the calcium or the phosphorus or the vitamin D, we have to supplement, right? We have to supplement that, and that will be okay. Now once you start supplementing, once we start supplementing, how will you come to know that your patient, how will you come to know that your patient is getting fine? How will you come to know the patient is getting fine? So there are two parameters to assess a patient of rickets, right? There are two parameters to assess your patient of rickets. The first parameter is to assess it by radiograph. How do we know that our patient is doing pretty fine with my treatment, with my management? So on the radiograph, what all we can see with the treatment, on radiograph with the treatment, what can happen? with the treatment there will be appearance of white line, right? With the treatment there will be appearance of the white line of healing. What do you call that? White line of healing. Okay, how does that look like, the white line of healing? The x-ray can show you absolute white line like this, right? Irregularity is a usual feature of the ricketic x-rays. Irregularity at the metaphyseal area, we call it what? Splaying and fraying, remember? So all the time writing is lagging too much. Okay, कुछ आपको सेटिंग चेंज करनी पड़ेगी क्या? देखो राइटिंग इज लैगिंग टू मच, स्टूडेंट बोल रहे हैं. Yeah, I can also see there is lag actually. There is a good lag I can see. So I've asked my team member if they can just check and do the needful. Let's see, let's wait for a while. Okay, all right. Fine. So I'll move now. I think now it should be okay. Some settings have been changed. I think it should be okay now. Okay, it should be better now. Just confirm guys if it is okay now. So white line of healing, yeah, it is going pretty fine now. Now it is going fine. So team has done some changes. Please confirm if it is okay now. So how do we know that our patient is working fine? So what do you look at on the x-rays? You look at the white line of healing. What is that white line of healing? There is an irregularity in the ricketic x-rays. And once you start treating the patient, no, they start showing you something like this. See, this white line you all can appreciate. This is called white line of healing. And how much time does it take for the white line to appear on the x-rays? It take only 1 to 1.5 months. Within 1 to 1.5 months, we can see this white line. The other way to assess your patient of rickets is to go for the metabolic assessment. And this metabolic assessment is done how? The metabolic assessment is done by the levels of alkaline phosphatase. It is done by the levels of alkaline phosphatase. Initially, in every case of rickets, guys, can you confirm please? Is the audio or video, the lag, is it less now? Is it still lagging? Okay. Some more settings have been changed. Just check now. Now, how is it? Dashmesh, Prachi, how is it now? Is it still lagging? I'm just waiting. Some more changes have been done. I'll just wait for a while and then I'll continue again. All right. So now I think we can go ahead. All right. Let's see. So I hope now things will be better. So level of alkaline phosphatase is the metabolic assessment of our patient's treatment, right? What do we do? See, level of alkaline phosphatase, they are always raised in the cases of rickets, okay, because they tell you about the increased blastic activity, right? So what happens with treatment? With treatment, they gradually becomes normal. They gradually gets normal, right? So radiographic assessment and the metabolic assessment. Radiographic assessment and the metabolic assessment. Okay, these are two ways. These are two ways to know that your patient is doing fine. How much time does it take for alkaline phosphatase to come back to normal? It can take a duration somewhere between 1.5 year up to 2 years, right? So that can be the duration for metabolic correction to be achieved. Okay, so this has been a previous question in your INICET or AIMS. I must say that time they asked it, what is the best time to operate on a child of some deformity of the legs in case of rickets, when you have a radiographic correction or the metabolic correction, so it is always and always the metabolic correction, right? It will always be the metabolic correction. All right, so remember that. So ricketic patients always have to be treated, operated surgically when metabolic correction has been achieved, that is alkaline phosphatase levels become normal. Okay, this white line, and one very characteristic sign is always the costochondral prominences in the chest. What do you call those costochondral prominences in the chest? Costochondral prominences in the chest, they are called as ricketic rosary. They are called as ricketic rosary. Now, what is that ricketic rosary? These are ricketic rosaries are the non-tender costochondral prominences, right? So, costochondral prominences are called as ricketic rosaries, which are non-tender. And how does it make a difference in the patients presenting to us in the OPD? See, this rickets and the scurvy patient, they may mimic two things. What are those two things? Rickets versus scurvy. In the rickets, we have the costochondral prominences which are non-tender, versus when you say scurvy, scurvy you all know that it is a collagen problem, right? It is a type 1 collagen defect. So there the bleeding tendencies are there, and therefore the costochondral prominences, actually they are tender. That is one difference. So white, this is one. Second is about the white line. See, in the cases of rickets, you are able to see the white line, which is called as white line of healing, which started with the treatment plan. But in the cases of scurvy, we see the white line, which is called as what? The white line of Frankel. See here, this is called as a white line of Frankel. Now, what exactly is this white line of Frankel? This is failure of resorption of the calcified matrix, right? This is the failure. See, the density of the rest of the bone has gone black, and this area is showing you white line. So in scurvy, if I go back to the primary page, what is the similarity here? The white line. But in rickets, the white line came when you started the treatment plan. In scurvy, the white line is a part of disease itself, right? And that white line is called as what? The white line of Frankel. That is called as the white line of Frankel, right? In rickets, it is white line of healing. In scurvy, it is white line of Frankel, right? Difference, tenderness and non-tender. Tender and non-tender. Okay. So costochondral prominences which are tender, which are non-tender. Costochondral prominences which are tender and which are non-tender. All right. I hope it is fine with everyone. Okay. Lots of lag. Sai is still the oh. Is it right? Is it going fine, everyone? What has happened? Just see, guys, the team has done further changes. I don't know, the net connection is very, very fast here, and I'm not sure why this lag is happening. Now, fine. Okay. Now, if it is fine, let me just. Okay, let's see. Let's see now. So, rickets versus scurvy, you are supposed to remember. Osteoporosis, we have discussed, you are supposed to remember, right? And also, please remember that how the deformities are seen, whether it is a part of in the legs, whether it is a part of varus type, whether it is a part of valgus type, or it is a part of windswept group of the deformity, where the legs can have both the deformities at a time, right? Now I think it is resolved. Okay, fine. Okay, okay, right. So now you all can check. You all can check, Prachi, Ishita, Sai. If you can please check now. Okay, so now see the next one after this. Yes, it is fine now. It is going fine. All right. Now after this, I want you to understand the most important topic would be the injuries here, trauma. Now in trauma, I want you to be focused upon this slide, right? I want to be focused upon this screen section here. Okay, see in the injuries here, in the injuries, open fractures. You all know what is open fracture. Open fracture is the one where the injury, the wound basically is there on the leg, on the limb, and the fracture sites are communicating. The fracture site is communicating with external environment, right? The fracture site is communicating with the external environment. That is the meaning of a open fracture, that you all know. And okay, and what is the classification which is used for the open fractures? The classification which is used for open fracture is called as the Gustello-Anderson classification, which can be very well a question for your exams. It can be a question for your exam matching side A with side B. They give you kind of injuries, they ask for the management protocol, or they may ask you like different kind of classifications, and they want you to match them with the other, sides, like for which condition which classification is to be used. Right. Okay. Number one, the first one, the type 3 injuries we know in the Gustello-Anderson. I want to remember all the three types. Type 1, it's a clean wound. Type 1 is a clean wound which is less than 1 centimeter. Right. Any clean wound which is less than 1 centimeter. And basically, these being clean, they are usually treated as a closed fracture only. You can treat them very well as a closed fracture. Type 2 injuries are the ones where the wound size is more than 1 centimeter, but the soft tissue is able to cover up the bone, right? Extensive soft tissue damage is not seen, and if it is extensive soft tissue damage, we call it type 3 injury, which is your open fracture. Type 3 is a clear indication, is the indication to put an external fixator, right? Now external fixators, you are expected to know of all the types. Okay, type 3 has been further divided as type 3A, type 3B, and type 3C. Type 3A are the comminuted and segmental fracture. Type 3B is the periosteum is damaged and the bone is exposed, and type 3C is the one where you have an associated vascular injury which requires a repair, right? What are the two special points about the type 3? That it has got no relation with the size of the wound. It can be any size. It can be any size. What it depends upon is damage to the soft tissue, right? And what are the different external fixators? Please do remember, they are very, very important. Different types of external fixators, I'm very sure you all can recall. They will be Ilizarro, that will be LRS, that is limb reconstruction system or the rail fixator, or the third one, the simple rods and clamps, right? The simple rods and clamps. These are three types, and rod and clamps can be applied in variable ways to the limbs. Rod and clamps can be applied in variable ways to the limbs. They can be applied as simply a uni-axial fixator only on one side. You can apply them on the multiple sides, so multi-axial, or around a joint, so we call them spanning fixator, right? So uni-axial, multi-axial, or spanning. These are variable ways to apply the fixators around the open fracture, right? Ilizarro, LRS, and rods and clamps. All right. So open fracture classification, definitely you all have to remember. This must be remembered by everyone. Okay. What are the different all right. So now it is going fine, guys, I think. Okay. So Prachi, Gajendra, Financial Shiksha. Okay. Then you have Sai, Ishita, everyone. Dashmesh, now is it going fine? The lag, I think, is not there. It is going very, very appropriately now. Okay, so these are different types of external fixators you should know. Open fracture classification, external fixators, you should know all of them, right? Now about the different, implants. I'm sure each one of you is having the PDF of the implants you have. The PDF of the implant is there in the DBMCI Premier group. Okay, you can download it from there itself. Just tag me there or in the orthopedic group, and you can have the file from there, PDF. It is already there in your eGurukul app, right? So the one I would just suggest all of you that when you're going for your exam, once at least go through the file of the instruments and the implants. It's very much required. All right. Then you have the other next one coming on to the specific injuries. In the specific injury, I want you to be very focused upon the Salter-Harris classification, right? That will be the Salter-Harris classification. What is that Salter-Harris for? Like we talked about the 5 zones of the growth plate, right? The 5 zones of the growth plate. So this Salter-Harris injury, it is for the injury to growth plate only, and we have discussed that point that in Salter-Harris injury, the most commonest layer of the growth plate to get into trauma is always the zone of hypertrophy, right? Now we have got 5 zones of the growth plates. We have got 5 zones of the growth plate: the S, A, L, T, and ER. This can be the mnemonic to remember it. But guys, remember, always and always, the prerequisite to learn the Salter-Harris classification is, the prerequisite is that you have to see the bone with dia on the top, the diaphysis on the top, then it is meta, then it is epi, right? You never change the sequence. You don't see it as the epi on the top and then you have the meta and then you have this dia. Don't do the upside down of the bone. See the bone from the lower part only, and once you see it from the lower part, then only the mnemonic Salter is going to be true, right? How is it? You all remember the Salter-Harris classification? It is very much required. So how to remember that? S here is for the injury to the same level. Same level means somewhere in the physis only, right? A is above. Now what is a part of the bone above the physis? You can see this. Above the physis, this is all the physeal layer, and we have the part of the bone which is metaphysis. And what do you call this fragment of metaphysis? This is called as the Thurston-Holland fragment. That's called as the Thurston-Holland fragment. Okay. L is for lower. Injury involving the physis and the epiphysis. T is the metaphyseal area, and epiphyseal area. SALT. ER, the last one is ER. ER is for eraser or crush. So crushing occurs through physis only. The 5 zones, they crush. The child is jumping from the height and all the 5 zones, they crush against each other. The Salter is the mnemonic, right? Salter is the mnemonic. And please remember, when you talk about the Salter-Harris, 3 important things. Number 1, Prachi has answered very correctly that the most commonest zone to get into trauma, it is hypertrophic, that we have discussed, number 1. Second, where do you see that metaphyseal fragment of the bone coming out with the injuries of the physis? Metaphyseal in this fragment, it is seen with metaphyseal fragment, it is seen with the type 2 injury. We call it what? Thurston-Holland fragment. That is called Thurston-Holland fragment, right? And third one, which grade of Salter-Harris injury has got the worst prognosis? So worst prognosis always and always is of the crushing, right? Okay, so this is the classification for growth plate injuries. This is the classification for the growth plate injuries. Okay, Salter. It will be Salter. All right. I hope it is fine with everyone. So don't forget these 3 things: hypertrophy, the Thurston-Holland, and the crush. Okay, these 3 are very important. The Salter-Harris classification. Then we talk about the specific injuries here. So in the very first one, I want you to remember a few basic things, right? In the INICET exam, please don't get worried about if you see something like very common part, some very common kind of injury. So don't get panic. Like in the last INICET exam that we had, there was a question about the ligamentous injury. Where they asked about this acromioclavicular ligament getting injured. Okay, so if you find some 1 or 2 extra kind of x-rays, don't worry at all about them. Just see to the question very carefully and you are going to find the answer for that. All right. Now, this one, the first topic of trauma I want to share with you, and I want you all to understand and remember all the time, is the dislocation of the shoulder. Okay, it's very simple topic. I'm very sure you all can recall that. So 4 points, shoulder dislocations, there are 3 types: anterior, posterior, and inferior. And out of all the 3, which one is the commonest one? Commonest one is always and always anterior one, right? It is always and always the anterior one. In the anterior, I want you to remember 4 important points, right? I want you to remember 4 important points. Number 1, how any dislocation happens, right? How any of the dislocation happens. Okay, so in anterior dislocation, attitude has to be when the person is trying to externally rotate his shoulder, right? Then only the head can come out. So it has to be abduction and external rotation. Second point is, in the anterior dislocation, we have got 3. Actually, there are 4. The 4th one is very uncommon. But the 3 common type of anterior dislocations, out of these, which one is commonest? Most commonest, it has to be subcorporeal, right? abduction, external rotation. Subcoracoid is the variant. Third point you should know that when you put a scale on the outer aspect of the shoulder, you can touch the tip of acromion with the lateral condyle. Right? What does it tell you? You can touch the tip of the acromion with the lateral condyle. That confirms that the contour of the shoulder is lost. Right? Please remember the third point, that in anterior dislocation, the contour of the shoulder is lost. So first point, abduction, external rotation. Second point is the commonest type, variant, and third one is the confirming about the loss of the contour of the shoulder. Okay, how to reduce anterior dislocation? The way to reduce anterior dislocation is by Cocker's method. Most commonest is Cocker's method. So fourth point I want you to remember is how to reduce it. That is Cocker's method. That is my team method. Okay, traction, external rotation, adduction, and medial rotation. So 4 points. Similarly, for the posterior dislocation, we have got again 4 points. How it happens? When there is a muscle, all the soft tissue is getting contracted, right? Adduction and internal rotation. And this happens in two special categories of the patients: electric shock and epilepsy, right? Number 3 is the contour of the shoulder in the posterior dislocation. It is usually normal, right? That is usually normal. And the x-rays, they show electrical bulb sign or the empty glenoid sign. What is that? Electrical bulb? It is something like this. The upper end of the humerus, it seems like the upper end of an electrical bulb. This is called electrical bulb sign, right? And the third dislocation we have is inferior dislocation. How does it happen? With hyperabduction and the salute position. Okay, so 4 points about the dislocations, anterior and posterior, and 2 points about inferior dislocation. Now, the most important part. What is common to all the three dislocations? Common to all the three dislocations is this slide you have in front of you. Every word written over here is very, very important. Okay, common to all the three dislocation is what? Common to all the three dislocation, it is the most commonest complication of the dislocation of shoulder. It is always the recurrence, right? That would be always the recurrence, right? And whenever there is a recurrent kind of dislocation happening, no, what may happen? The bones may damage each other. Okay, once the bones damage, they can produce some defect onto each other. The defects on the glenoid is called as Bankart. The defect on the humeral head is called as Hill-Sachs. So Hill-Sachs is seen on the upper posterior lateral aspect of the humeral head. Hill-Sachs is on the posterolateral aspect of humeral head, and Bankart is on antero-inferior margin of the glenoid, right? Glenoid, this Bankart has been a past question of your INICET only, right? So these are the lesions which are seen when the bones dislocate and they damage each other. Most commonest, if somebody asks you the acute complication, if someone asks you the most commonest acute complication, then it has to be axillary nerve injury. If injured, it leads to a trouble with deltoid and teres minor. They will not be working. So patient's abduction 15 to 90 degrees, having a difficulty, and external rotation becomes weak. Second is loss of sensation on the upper lateral aspect of the arm area. That is called as regimental badge sign. That is called as what? The regimental badge sign. Okay. So sensory component, motor component, the defects of the bone. Okay. So Gustilo-Anderson type 2 wound will be treated as closed fractures? No, not at all. Type 2 is any injury more than 1 centimeter. Okay. And it depends upon that how is it presenting. So you can treat it type 1, you can treat it type 3 depending upon how much is the wound, how much is the size of the wound, and how much is the kind of injury you have, right? So type 2 will have a variable kind of management plan. Type 1 usually has a closed injury. Type 3 external fixators. In between you have the type 2. It depends upon what kind of presentation it is happening. What kind of presentation it is happening there. Okay. All right. Okay. So this is the shoulder dislocation part. This is the shoulder dislocation part. Right. Now next after this one is always the most important after the shoulder injury is the supracondylar fractures. But before that, there is a slide I have to show you. Right. This slide I want to show you is about the 3-point relationship in the elbow area. 3-point relationship in the elbow is basically seen in a flexed elbow. Right. It is seen in a flexed elbow. Okay. So in the flexed elbow, how do we see this? How do we see this in the flexed elbow? So in the flexed elbow, you can see them in the manner of a triangle, right? That is what you see when the elbow is flexed. In the extended elbow, all the 3 points will be lying in a straight line. Okay, all the 3 points, they lie in a straight line. All right. Now see, they ask you this question. This has been the question in the previous year's INICET November 23 as well, right? What are the conditions when the triangle will be damaged, maintained, or reversed? So damage means as simple as that. There are 3 points here and 3 points are broken. So triangle is broken. Olecranon, lateral condyle, medial condyle. And when will it be maintained? It will be maintained when you don't touch the triangle. That is, stay above the triangle or stay below the triangle, right? Stay above the triangle or stay below the triangle. That is supracondylar humerus, and it is reversed in posterior dislocation of the elbow area, right? So supracondylar fractures are one of the most important entities around the elbow area, right? They are one of the most important entities around the elbow area. Okay, so now see conditions. Do remember these conditions. Don't try to mug them up. Please understand that the 3-point relationship we have. Okay, 3-point relationship we have. All right, so this is one about the 3-point relationship. Now, one of the most important injuries I want to tell you, one of the most important injury I want to tell you here is the supracondylar. Very, very important from clinical point of view, from exam point of view, everywhere, it is very important. So supracondylar injuries, they are of two types. Okay, you all know very well, they are of two types. You can see on the screen as well, right? You can see on the screen as well. Supracondylars are of two types. They can be extension type or they can be flexion type. Okay, they can be extension type or the flexion type. Okay, I hope it is going fine now. Okay, right. Uh, all right. Okay, so extension and flexion type, how do you define them? Extension and flexion? Very basic rule that it is defined by the position of distal fragment. So you can very well appreciate the image number C here. Right here, the distal fragment is pointing towards the back side. It is pointing towards the posterior aspect. All right. So it is an extension type of injury. It is a extension type of injury. Right. Now in the second one, B, we have the fragment moving towards the flexor side. So it is a flexion kind of injury. 98% of the supracondylar fractures, they are extension type injuries. Okay. The classification which is used for supracondylars, what is the name of the classification? Remember the name, it is Gartland classification, right? Remember the name, it is Gartland classification. And the most important thing, what you have to remember about the supracondylar is the complication table here that you can see. The complication table that you have in front of you. What all can be the possible complications for supracondylars? Okay, what all can be the possible complication of supracondylars? What are the possible complications? They can happen immediately, they can happen in the early phase, or they can happen in the late phase, right? Early, immediate, or late. All the three phases, they can have their own complication. Now, immediately, what all can happen? Immediately, always any fracture, when gets, bone gets injured, getting any fracture, or the joint getting dislocation, what is the immediate thing that happens? It is always the neurovascular compromise, right? It is always the neurovascular compromise. So what is our nerve? What is the vessel over here? So nerve in the vessel, the artery here, it is the brachial artery. The artery here is the brachial artery, and the nerve involved is AIN, right? Anterior interosseous nerve. It is the anterior interosseous nerve, most commonest, which you should always remember is a branch of which nerve? Come on, quick. Which is a branch of which nerve? This AIN. Tell me about this. AIN is a branch of which nerve? It is a branch of median nerve. And what is the clinical test that you do to test for this anterior interosseous nerve? What is a clinical test that you do to check this anterior interosseous nerve? It is OK sign, right? That would be OK sign, right? So OK sign is being done to know about if the AIN is okay or not okay. If the AIN is okay or not okay, right? That is, yeah, that is for anterior interosseous nerve. So brachial artery, brachial artery or anterior interosseous nerve. Early complication is the ischemia of the muscle, which is simply called as a Walkman's ischemia. And if you don't deal with that, it lands up into compartment syndrome, right? And if compartment is not dealt well, then it leads to permanent damage to the tissues, which we are calling as the contractures here. Called as what? The Walkman's ischemic contracture. The Walkman's ischemic contracture. And overall, the most commonest complication that you can see in fracture supracondylar humerus overall is always a malunion. Metaphyseal area, right? Metaphyseal area, and high vascularity area, cancellous bone, breaks easily, heals easily, and that is why you see the malunion here. And the deformity that we see happening with, very good Prachi Gajendra, the deformity that we see occurring with malunion here is simply the cubitus varus, which you also call as gunstock, right? And the last is the myositis development. Okay, I want you to remember the cubitus varus here. I want you to remember the compartment syndrome here. I want you to remember the AIN here, and I want you to remember this brachial artery injury here. Right? These are different questionnaires from here. Now, compartment has been one of the most frequently repeated question in the recent years of INICET as well as the NEET exam. Right? In the NEET also it has been asked. Now, see, these are few points about the compartment syndrome in front of you. Above what pressure do we say that the pressure in the compartment is dangerous now for the soft tissues? It is always more than 30 millimeters of mercury, right? And the most commonest fracture, the quickest one to develop the compartment syndrome, it is always the fracture diaphysis of tibia, right? Third, the muscle which is most commonly involved, FDP, the nerve to be involved is AIN. And commonest symptom, the most commonest symptom is always the pain, right? But if they ask you about the sign, please remember difference in the symptom and the sign. Don't make a mistake there. Sign has to be the pain on passive stretch. As the treatment, if you have to do the fasciotomy, then you go with the superficial as well as deep fascia, right? Okay, and pulselessness keeps on coming over and over again in the social medias. That is it late or is it last? So always remember, pulselessness is always a late feature of the compartment syndrome. It is not the last one, it's a late feature of the compartment syndrome. It comes late, right? It comes late. Okay, so always remember these points about compartment syndrome, right? After compartment, the other injury which I want you to remember, very important clinical, yeah, very good Prachi. Okay, Dhana Manjuri. Okay, Dhana Manjuri. Okay, fine. You both are right, guys. Very good. Now see, lateral condyle of humerus. Why is it important? Because it is called as a fracture of necessity, which requires a fixation all the time. And if you don't fix it, you know that there is an attachment of common extensors over there. If you don't fix it, if you don't operate it, if you don't do surgery, what is going to happen? What happens here is non-union, right? And if non-union happens, the forearm of the patient starts going laterally and laterally and laterally, and it goes into valgus, right? It goes into valgus. And when it is going into valgus, then what happens? The nerve to get involved is the ulnar nerve, and it is a late involvement of the ulnar nerve. That is why we call it tardy ulnar nerve palsy. Then we call it tardy ulnar nerve palsy. Okay, this is tardy ulnar nerve palsy. All right, so fracture of necessity, it requires fixation, should be always fixed. Very good, Gajendra, you're right. And see, please remember, in your exams, you get a question on any of these three. They are always the fracture of necessity, always have to be operated. This is a list of your fracture of necessities. Operate all the time, right? Operate all the time. Never ever you should tell them that we have to go for conservative management. So lateral condyle of humerus, neck of femur, Galeazzi, always operate. But the other fractures which require surgery, the two-part patella olecranon, when they are displaced, right? When they are displaced, lower third ulna, lower third of tibia, it depends, variable, low vascularity, and displaced intra-articular fracture and Montegia, they are always supposed to be, fixed, always supposed to be fixed. Two most important fractures which I want you to remember all the time from the forearm area are the Montegias and the Galeazzi, right? Look at these two images, the Montegias and Galeazzi. Now these are two in front of you. You have Montegia here, right? How to define Montegia, how to make a difference with the Galeazzi? How to make a difference with the Galeazzi? Montegia and Galeazzi. See, M for M. No mistakes here. M for M. M is the medial bone. M for the medial bone, right? Montegia is the fracture of the medial bone, that is ulna. So when there is a fracture of proximal 1/3 of ulna, we call it Montegia with dislocation of the proximal radio-ulnar joint. With dislocation of the proximal radio-ulnar joint, right? That is called as Montegia. All right. This is Montegia, and when you have a reversal of Montegia, absolute reversal, is called Galeazzi. What is that? Fracture of the distal 1/3 of radius, fracture of distal 1/3 of radius with dislocation of the distal radio-ulnar joint. With dislocation of the distal radio-ulnar joint, right? That is distal ulna. This is called Galeazzi. Remember that Montegia is called as a classical Montegia when there is a fracture of the proximal ulna with dislocation of the proximal radius. That is called classical. Both the things have to be there, right? Both the things have to be there. If it is only fracture of 1/3 of ulna, it can be called as a Monteggia variant, right? That is a Monteggia variant we have. Then in Galeazzi, it is a fracture of distal 1/3 of the radius with dislocation of the distal radioulnar joint, that is distal ulna. All right, these are two important ones. Monteggia most commonly involves which nerve? As you can see, it is near to the head of the radius, so it most commonly involves the posterior interosseous nerve. And if PIN is involved, what it is going to lead to? It leads to the failure of the extension of the fingers, which we simply call as the finger drop. Simply call as the finger drop. All right. So this is the finger drop we have. So Monteggia's finger drop, the nerve involved is the posterior interosseous nerve. Now guys, this is the area where we often do the mistakes in the exams. The fracture happening on the medial side of the forearm and the nerve involved is of the lateral side, right? And the lateral condyle of humerus getting injured on lateral side and the nerve involved is of medial side. Okay, so two most common mistakes done in our exams, the cross areas. Okay, so please remember that the cross areas. Okay, these two not to be marked wrong. After Monteggia and Galeazzi, the two most important injuries. The other one is the injury around the wrist. Now I want you to remember everything about the wrist, how to do the labeling of the bone, right? How the fractures are defined. So when you say the wrist area, when you wave your hand like that, okay, when you wave your hand like that, where exactly are we talking about? What exactly are we talking about? Wrist simply means the radiocarpal joint, right? The wrist simply means the radiocarpal joint. Okay, radiocarpal joint, the radius and carpals. Ulna doesn't make a part of the wrist joint, right? It is not making a part of the wrist joint. So what are the fractures we can see at the distal end of radius? At distal end of radius, we can see two kind of injuries: extra-articular, right, on the top, and intra-articular here. Extra-articular and intra-articular, right? Extra-articular means the fracture stays away from the joint line. Intra means just above my head, you can see here, the fracture goes into the joint area like this. So when it is extra-articular, we have got two injuries, Colles and Smith. And intra-articular, we have Barton and Schoffer. We have the Barton and Schoffer. We have two injuries, intra and two extra. Okay, so it is intra and extra. What are the extra articular injuries? The Colles and Smith, Bartons and Schoffers are intra-articular. How to make a difference between the Colles and the Smith? What is a parameter to make the difference? The Colles and Smith are divided by or differentiated by these displacements. So what are the displacements we have in Colles? We have got 6 displacements. Okay, lateral displacement, lateral tilt, impaction, dorsal displacement, dorsal tilt, and supination. These are the displacements which can be seen in the cases of Colles. These are displacements of Colles. Okay, and when it is exactly reverse of the Colles, we simply call it the Smith injury, right? We simply call it the Smith injury. Instead of lateral, it goes medial. Instead of dorsal, it goes in palmar. Instead of supination, it goes in pronation. That is how you define the Smith injury, right? That's how you define this Smith injury. Okay, so Colles and Smith, the Colles and Smith. Okay, how are the deformities seen in Colles and Smith? How to make a difference? Now look at these X-rays. I want everyone to mark it very, very correctly. Okay, the X-ray A here, you can see the fragment, distal fragment towards the shadow of the thumb. So this has to be which X-ray? This has to be Smith, right? This has to be Smith. And if you look at the other one, this is thumb here, image B here. The distal fragment is facing towards the dorsal side, right? So the second one is Colles. So when fragment goes on the dorsal aspect, we call it Colles. When it goes on the palmar side, we call it Smith. Okay, no mistakes. And therefore this Smith, when it is going like this, see, when it is getting a depression in the front, the fragment goes in front, depression on the back. This is called as the garden spade. You all know this. This is called as garden spade deformity. That will be garden spade deformity. And when you see the fragment having a hump on the back, this is called as what? This is called as the dinner fork deformity. This is called as the dinner fork deformity. All right, the dinner fork deformity we have. Okay, so now when you see the other two injuries, they are Barton and Schoffer. Barton and Schoffer. Now see this Barton is defined as comminuted intra-articular fracture. They are defined as comminuted intra-articular fracture, which are usually displaced. And the other one is what you call a chauffeur. What is chauffeur? Chauffeur is defined as the fracture of the radial styloid, right? They are the fracture of radial styloid. So Colles, Smith, Barton, chauffeur, 4 fractures at the wrist area, right? Very, very important. Next, in the wrist, we have the scaphoid, and every single line you can read out for the scaphoid is your MCQ in the exam. How they are asked? See, scaphoid, this is a labeling which I want each one of you to remember all the time. The wrist labeling here. See, wrist is radiocarpal, we said already, and how the labeling of the bones are done. All the 8 carpals you should be able to identify. Now, scaphoid is the most commonest carpal to get a fracture line, right? It is the most commonest carpal to get a fracture, and the site for fracture is waist. If waist is getting fractured, for avian, the site for avascular necrosis, it is which one? Site for avascular necrosis, it has to be the proximal pole, right? That has to be the proximal pole. Okay, absolutely right. And tenderness clinically is always in the anatomical snub box. Okay, treatment is always first the plaster to be given in the glass holding position. And what is the most often seen complication? It is always and always non-union followed by avian. And if you are suspecting somebody having avian or non-union, always go for MRI, right? What is that special kind of screw which is used in the scaphoid? That is called as the Herbert screw. Okay, that is called as the Herbert screw. That's called as a Herbert screw. I hope it is fine with everyone. Now let's see. Second point, or the second carpal I want to remember is this lunate, right? That would be lunate. Lunate is the most commonest carpal to dislocate, right? And when it dislocates, when alone it dislocates, then we are only going to call it lunate dislocation. But when lunate stays on the position and all the carpals have gone dorsally like this, then we call it perilunate dislocation, right? Then we call it the perilunate dislocation. So what is lunate dislocation? It is only the lunate dislocation. What is perilunate dislocation? When the periphery of the lunate is dislocated, everything around the lunate gets dislocated. All right, so lunate and perilunate, lunate and perilunate. Okay, remember this, lunate for dislocation, and whenever the scapholunate dissociation happens, what do we see there? It is called the Terry-Thomas sign, the gap between the front 2 teeth of the Terry-Thomas. Okay, that is called as Terry-Thomas sign. That's what you call the Terry-Thomas sign. All right, so this is about your lunate. Now, in the hand, I want to remember at least Bennett. Base of the first metacarpal here, this one. Base of the first metacarpal, what are the fractures which can be seen? The base of first metacarpal, we can have Bennett or we can have Rolando, right? Bennett or Rolando. So Bennett fracture, how do we define that? Bennett is basically partial intra-articular fracture. Bennett is partial intra-articular fracture, and Rolando is a comminuted intra-articular fracture. How do you think you should treat Bennett? Bennett is usually treated by internal fixation. Why? Because there is this muscle attachment called as which one? Abductor pollicis longus. And because of this attachment, the fragment doesn't stay in position and it is getting pulled, right? Then it is getting pulled. So it is abductor pollicis longus. It is abductor pollicis longus. All right, that would be abductor pollicis longus. All right. So this is the hand injury. This is about the fractures at the base of the first metacarpal. Fracture at the base of the first metacarpal. I hope it is fine. The scaphoid, lunate, Bennett, Colles, Smith, deformities and their treatment plan, right? They should be very, very clear to all of you. Okay, they are all important for your INICET exams. Now, after this injury, let's talk about some of the injuries of the spine, right? What are the fractures of the spine? So these are 4-5 injuries which I want you to remember again, recall again. So motorcyclist fracture, the hinge fracture of the skull, dividing the skull into 2 halves, the anterior half and the posterior half, usually via middle cranial fossa. Second one, Jefferson fracture, fracture of the atlas bone, right? The C1. Hangman, hangman is what? Hangman is the spondylolisthesis. Okay, it is the spondylolisthesis of C1 or the C2 basically over C3, right? The C2 over C3. Then we have the whiplash. Whiplash is what? Hyperextension followed by sudden flexion. Hyperextension followed by sudden flexion. What is chance? Chance was a recent session question of the INICET only. Chance is flexion distraction injury. Okay, linked to the seat belts. It is linked to the seat belts. Okay. Okay. Right. So Clay-Shawler is what? Avulsion of the spinous process. Right. So it is avulsion of the spinous process. And which spinous process should be avulsed? Usually the longest one. Okay. Right. So this is the avulsion of spinous process. So these are some of the injuries you have in the vertebrae. Right. Chance is the flexion distraction, usually a dorsal spine injury. Clay-Shawler, avulsion of spinous process. Then whiplash, again neck, the sprained neck, Hangman's spondylolisthesis, and Jefferson C1 fracture. Okay, it is, yeah, these are all the injuries of the spine. Now, after this, what I want you to focus upon in the spine are three important topics here. That is, one is your scoliosis. So, quick points about the scoliosis. Quick point about scoliosis. See, scoliosis is defined as lateral curvature with the rotation of the spine, right? Why would somebody have developed this scoliosis? It is developed because of two broad reasons. We say we divide them into two categories. Either it is congenital or it is idiopathic. Okay, it is congenital or idiopathic. All right. Now see, in the congenital one, there has to be anomaly with the vertebral formation, anatomy, and that can happen with the wedge vertebra, with a hemivertebra or a block vertebra. These are anomalies only, right? These are anomalies only. Okay. The scoliosis always will be defined by the convexity of the spine. What is the reason behind that? Because on whichever side is the spine convex, that side organ usually get a compromise, right? And how do we measure the angle? What is the angle called as? The angle here is called as Cobb's angle, right? It is called as the Cobb's angle. Okay. Okay. So now last one, Adams here. Adams test is why? Why do we do that? Adams, and what is that? Adams is nothing special. It is just a forward bending test, right? It is just a forward bending test. The person stands straight and bend forward. Why is it done? It is done to differentiate between the postural or what you call as normal, posture related or the long stature patients, those who show scoliosis versus pathological one. So whenever the person is bending in front, the normal person who doesn't really have the scoliosis will not be showing it, right? That will disappear, but the pathological one is going to have that. That is called as the Adams test, right? That is called as Adams test. Treatment plan, braces, guys. Please do remember the braces, the Milwaukee brace and the others like the Dennis Brown splints and all. So braces splint should always be clear, and the PDF of that is already in your e-Gurukul app, right? So children's usually come up with the Milwaukee brace. Adolescents, they come up with the Boston brace. They can be treated basically. So children's with the Milwaukee, adolescents with the Boston's or the Rizzers cast, and adults, they usually require a surgery, right? And the surgery will be fusion of the spine in the straight level. Okay, and that spinal fusion is done by the usage of pedicle screws. It is done by the usage of pedicle screws. Okay, it is done by usage of pedicle screws. All right. All right. So this is about your scoliosis. So pedicle is the only way. I'm sure each one of you, yeah, very good, Kajal, you're right. Sunny, you're right. So most, I do believe that each one of you is able to recall the parts of the vertebra. All of you can like recall what was pedicle, what was lamina, what was pars. Go through the basic anatomy. Don't do any mistakes in these simple questions, right? Okay, right. So these are all the points about your scoliosis. Now, second point is about listhesis. See, there are two words, lysis and listhesis. Lysis means a break in the pars interarticularis. Break in the pars interarticularis. Okay. So, pars makes what part of the dog? You remember the dog here, what we are talking about? Let me just show you this one. When you talk about this dog, what are the, what kind of view is that when you look at this dog? So, this dog is here in the oblique view of the vertebra, right? It is in the oblique view of the vertebra. We can see that. You can see this shadow here. You can make out this picture over here, right? So this is the dog we all can make out, and each part of the dog is being formed by some part of vertebra. So whenever this dog, which is seen in oblique view, please remember this, it is an oblique view of the lumbar area. It is an oblique view of the lumbar area, right? It is an oblique view of the lumbar area. And in this, what you can appreciate, is the dog. The dog is best visible in the oblique view, and whenever there is a break in the neck of the dog, what do you call it? Spondylolysis, right? That is called as spondylolysis. So lysis means what? It is simply the break in the neck of the dog, which will be best visualized in the oblique view, right? Which is best visualized in oblique view. Okay. Now see, whenever there is a lateral view being seen, lateral view can show you there is a slip of the vertebral body. There is a slip of the vertebral body, and this slip of the vertebral body is called as listhesis. So listhesis is best seen in the lateral view, right? Lysis is a break in the neck of the dog, so we simply call it the B-headed Scottish. Okay, so this is the B-headed Scottish dog appearance, right? This is the B-headed Scottish dog appearance, and this B-headed Scottish dog means just a cut. When sometime they mention in your multiple Q bank or somewhere that there is a collar. Collar means there is a gap between the head and the body, and that might be representing your listhesis, right? That might be representing your listhesis. Okay, right. So they might be representing your listhesis, and for listhesis you should always remember the best view required is always a lateral view. All right. Now see, sometime when the slip is too much, it may show you something very special called as the inverted Napoleon hat sign. What is that? When the L5 S1 has already slipped onto each other. Okay, when L5 S1 has slipped onto each other, the two bones they overlap, and when they overlap, they make a shadow like this, like a hat to be worn between L5 and S1, and that is called as what? Inverted Napoleon hat sign, right? Yeah, that is fine. It is going fine, no? Okay, so it is called as the inverted Napoleon hat sign. That is called as the inverted Napoleon hat sign. All right, so three things: B-headed dog, 1; collar around neck, 2, which might be suggestive of the slip, for which we need is a lateral view, and 3 is the inverted Napoleon hat sign. Right? It is called as the inverted Napoleon hat sign. Okay, this one. Okay, G. Okay, fine. Now it is all right. So it is going fine, I guess. So next one. So after this listhesis, one very important concept is of the disc prolapse. Now here, no mistakes ever to be done, right? In this, no mistakes ever to be done. Disc prolapse, please remember the concept here. We have got three kind of nerve roots here. One in the central area, which can be the spinal cord or the cauda equina. Now, when you look at the L4, L5 area, it has to be cauda equina only, right? Then you have a nerve which is going out to supply desired area. This is called exiting nerve, right? This is called exiting nerve. And the one which goes all along the central structure, it is called as the traveling route or the passing route, right? Most commonest compression is when the nerve gets compressed here next to the center, right? When the nerve gets compressed next to the center, and this kind of compression is called as what? This kind of compression is called as what? Okay, it is the paracentral compression. Please remember, this is a paracentral compression. So when there is a paracentral compression happening, it is going to compress the nerve root which is next to the center, right? This is the most commonest type of disc prolapse. And if you talk about the nerve passage, if you talk about the nerve roots passing from a particular level, should always remember which nerve passes from where. So between L4 and L5 body. Okay. 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 Now see this one, when you talk about L4, L5 level, the root which is going out here below L4 body is L4, right? That root is L4. And okay, this one which is traveling is L5 root, right? So always remember at which level which root is exiting and which root is traveling between L4 body, L5 body. The L4 will be going out, right? And L5 goes next to the center. We call it what? Paracentral. We call it what? Paracentral. Right. So this one, please remember, this time when they ask the question, they just mark the arrow like this. They mark the arrow at L5 and S1 and they mark this area and they said the patient is coming to you with a backache and with radiculopathy and the patient is having this numbness, tingling, all that feature on the back side of the thigh. So between L5 and S1, which root should be most commonly compressed? So always remember it is a paracentral, and who is going to be the paracentral one? It is S1. It is S1. Okay, so S1 root is the one which is going to get compressed most commonly between L5 and S1, and that is going to compress upon S1. When it is compressed, it is going to present as a numbness, as the tingling going through back of the thigh. So here you are expected to remember the dermatomal levels, right? You are expected to remember where all what is getting supplied by which nerve, right? Where all what is getting supplied by which nerve. So this is your listhesis, lysis, disc prolapse, and the concept of disc prolapse. Please, no mistakes, guys. Right? These are very commonly repeated questions, and these are the common patients in our routine OPDs. So you can expect these questions to be repeated all the time, right? All the time. All right. So this is all from this listhesis spinal area. Okay, listhesis or the spinal area. Now let's see the next one. The next one we have is, let's move on to the next fracture. Let me just give me a moment. Let me just open that up. Right. All right. So let's continue with the rest of the trauma section. What all is further important here? So next one is the neck of femur. Now I come on to the lower limb. Most important injury, the neck femur. And I want you to remember, first of all, most important thing about the neck of the femur, it is about the classification. Right? It is about the classification. Classification for neck femur, the most commonly used is anatomical classification. And how do we use that anatomical classification? Anatomical one is dividing the fractures into three types: the subcapital, transcervical, and basicervical. And these are, intracapsular injuries. These are intracapsular injuries, right? Okay, these are intracapsular injuries, and you know that intracapsular injuries are having the risk of developing into avascular necrosis, and that is why intracapsular injuries should be treated without opening them. So we treat them by the method of what? Close reduction, internal fixation. And this other one, the third one, is the basicervical. Okay, and the basicervical fractures are always outside the capsule, so we can easily open them and we can fix them nicely, right? We can fix them nicely. Okay, so ORF or CRIF, it depends upon whether you are working inside the capsule or whether you are working outside the capsule. So subcapital, transcervical, and basicervical. Okay, subcapital, transcervical, and basicervical. Anatomically, okay. Most important thing would be the treatment plan. This is a common thing to be asked, and please remember how to answer for the treatment plan as well. See, it all depends upon the question number one. Whenever any patient comes to you with a fractured neck of the femur, the most, can an MBBS student watch this session? Yeah, every MBBS student can watch this session. This is for MBBS only. It is not for PG, right? So it is for MBBS only. So why do you feel like it is not for MBBS? Any specific reason? Okay. So age of the patient here is the first most important primary criteria to decide the treatment plan, right? Age of the patient, if the patient says is more than 65, no second question to be asked, right? Carry on, man. Okay. Gajendra. Okay. I don't know why, for whom you have written this, Gajendra. I am not very sure. But anyhow. Okay. So more than 65, the only plan you have is to go for the replacement, right? No second question to be asked. Okay. Yeah, so this is replacement part, and when the patient's age is less than 65, the aim has to be to save the original head. Okay, to save the original head. Now, how to save the original head? It depends upon the duration. Why? Because that duration, I'm expecting to understand whether the bone is developing avian or not developing avian. All right. Now, when you are talking about avian, you should get a MR done. Okay. Okay. So now, when patient is not having any necrotic patch, MRI is not showing about necrosis, presentation is early, then my plan is to fix it as early as possible. Okay, it is to fix it as early as possible. Okay, so what exactly has to be done? It depends upon whether the injury is intra or extracapsular. Okay, it is intra or extracapsular. So when it is inside the capsule, as we discussed, don't open the capsule, fix it without opening it. So what is to be used? The cannulated cancellous screws. And if it is outside the capsule, go for a DHS. Open it well and just fix it well. All right. Late presentation. Late presentation means some necrotic patch might be developing, so you have to provide a new blood supply. How to do that? That is done by Mayer's pedicle graft. That is done by the Mayer's pedicle graft. All right. Now, what are the common complications linked to the fracture femur? It is avascular necrosis and non-union. Okay, avascular necrosis and non-union. All right. Avian being the most commonest complication. Don't forget that. Avian has to be the most commonest complication, followed by the second one, which is non-union. All right. So these are the different surgeries. These are different questions you have from the fracture neck of the femur. Other than that, the next part is always to remember about the dislocations of the hip. That is again very, very important. This table in front of you is one of the most repeated MCQs of your proximal femoral area. That is a dislocation of the hip, right? In the dislocation, like the shoulder, here too we have three, but instead of inferior, here we have the central one. How they happen? Most commonest of them is always a posterior one. Most commonest of them is always a posterior one. Why? Because of capsular deficiency on the posterior side, right? Because of capsular deficiency on the posterior side. That is the mechanism which has been described as dashboard. Okay, so person sitting with the hip adducted, flexed, there is an impact on the knee and the hip goes back. This posterior dislocation, okay, it creates shortening, adduction, internal rotation of the limb, and as the head of femur is going back, it can hit on the sciatic nerve. If the sciatic is gone, it can create a foot drop. If the sciatic is gone, it can create a foot drop, right? That will be foot drop. Anterior dislocation, it creates a lengthening of the limb, and that's really a true lengthening. Okay, and the head of femur comes in the groin area. And what do we have in the groin? The femoral vessel. So if they again ask you in the INICET that vascular compromises are more common in anterior or posterior, so you know very well that vascular compromise are more common in anterior dislocation because they are going to damage the artery, femoral artery. Posterior dislocation damages the sciatic nerve, so they produces neurological compromise, right? So yeah, so now the central fracture dislocation, it perforates the acetabulum and goes in the pelvic cavity, right? That creates a shortening for sure. Okay, and the head can only be examined on the per-rectal examination. Okay, it can be only examined on per-rectal examination, right? Two most important topics from here: proximal femur, the neck femur, and the dislocations, right? After that, what I want you to remember is about the concept of patellas. Patella here. So in patella, please remember these two things. Patella, undisplaced. If patella, you know, is the biggest sesamoid we have, right? It is the biggest sesamoid we have. And patella, if it is an undisplaced fracture, what is the plan? Plan is cylindrical cast or the tube cast. And if it is a displaced two part of the patella, you know very well that it becomes a fracture of necessity. Okay, it becomes a fracture of necessity, and that has to be treated by tension band wiring, right? So two most important things to be remembered from here: undisplaced fracture of patella and two-part fracture of patella. Two-part is a fracture of necessity, operate the tension band wiring, and if it is undisplaced, we go for a cylindrical or a tube cast, right? In the knee, please do remember that how the structures are arranged in the knee, how the structures are arranged inside the knee. Anterior cruciate, posterior cruciate, meniscus, where all these structures are. So when I hope you all are aware of the mnemonic we learn as the medical, when you look at this tibia, no, when you talk about the tibia, when you look at the upper surface of tibia, if this is anterior aspect, this is posterior aspect, and when you look at all the structures, how they are arranged, how are they arranged? So all the structures looking from anterior aspect, you can remember the mnemonic all the time. Which ones? The Medical College Lucknow, LMCL and LMC. Medical College Lucknow and Lucknow Medical College. Please do remember this. From anterior to posterior, how the structures are arranged. M here stands for menisci, right? M, if it is anterior side, it has to be the anterior part of the menisci. M is for medial menisci. So anterior horn of medial menisci, right? C is for cruciate. So we have anterior cruciate ligament here, and L is for lateral meniscus. Which part of lateral meniscus? It is anterior horn again, right? Anterior horn of the lateral menisci. Then we have this L here. This is the posterior horn of lateral menisci. This is the posterior horn of medial menisci. And then we have the C. The last structure on the knee is PCL, posterior cruciate ligament. Posterior cruciate ligament. Okay, so this one, please remember, is the sequence of arrangement of the structures in the knee. Anterior horn of the medial menisci, anterior horn of the this ACL, and anterior horn of the lateral menisci. Lateral meniscus is the last to start on the anterior side and the first to end on the back side. It's the smallest C we have in the knee, like this, right? Remember the structure. The posterior most part of the tibia will be giving attachment to the PCL. Okay, now see, if you talk about the ACL, okay, so when you have the ACL or the PCL, no, when you have the X-rays like this, if you look at this X-ray, if you see some avulsion of the bone here, then you know it is a PCL attachment. Okay, it is PCL attachment over here. Okay, fine. So when ACL and PCL, when you're talking about these two ligaments, no, you should know why they are called as A or P. So I've told you the reason. It is the anterior part attachment on the tibia. This one is attached to the posterior part of tibia. That is why A or P. MCL, LMC from anterior to posterior. Mega, you're absolutely correct. Very nice. Okay, so when you talk about ligaments and the cruciates, the cruciate ligaments and the menisci, these two things, please don't forget. Okay, please don't forget that most of the part of these two is absolutely avascular, right? This is absolutely avascular. So when it is avascular, that means healing chance is almost nil. You have to operate on them to remove them and to either get a new one or just excise that part. Okay, so when you look at the ACL PCL, what are the most important clinical tests you should remember all the time? The draw test, and the Lashman test. So draw will be done with the knee flex to 90. Draw will be done with the knee flex to 90 like this, and Lashman will be done with the knee flex to 20. In the knee, the most commonest ligament to get damaged is the medial collateral ligament. Please remember, it is the MCL. Okay, it is a MCL is the most commonest ligament. And when you talk about menisci, please remember, most commonest menisci to get damaged, medial menisci, right? Most commonest pattern of tear, it is vertical tear. Most commonest is vertical tear. And the best investigation all the time is arthroscopy. The first investigation all the time is MRI, right? Best is always scopy. Why? Because all the time, you get with the camera into the knee joint and you can see what all is injured there. Okay, so now when you just look at the menisci, these are cartilaginous. They have a little firm consistency, so they keep on eroding the surface and they can damage the bone, right? So meniscus, which one? The medial menisci is the more commoner, medial collateral is the more commoner, anterior cruciate is the more commoner. When somebody has the damage to all the three here, medial collateral, anterior cruciate ligament and medial menisci, what do we call it? We call it terrible triad of the knee or terrible triad of O'Donnell's, right? Okay, right. So this is the terrible triad of the knee area. In the elbow also we have a terrible triad of elbow. You remember the terrible triad of elbow? What are the structures in terrible triad of elbow? So it is the posterior dislocation of elbow we see, right? Posterior dislocation of elbow, radial head, as well as the coronoid, right? When you have in the elbow these three getting damaged together, when you have all the three getting damaged together, that is called as terrible triad of elbow. And in the knee, it is a terrible triad of knee, right? Okay, these are called as terrible triad of knee and the elbow area. Knee has been a question of your INICET in the last year, right? Terrible triad of elbow is also equally important. Okay, so these three. In the ankle, I want you to remember all the ligaments here, right? All the eponyms here. So eponyms will be, this is the medial malleoli, this is lateral malleoli 1 and 2, and 3 is the lateral, the posterior malleoli, number 3. Okay. Okay, fine. So now when you look at different eponyms, what is Pott's fracture? Pott's is bimalleolar fracture. Both the malleoli, lateral and medial. Cotton's is trimalleolar fracture. Pylon is any intra-articular fracture. And mesonev is ankle fracture with proximal fibula fracture. Okay, right. So these are all the fractures which are called as the eponymous at the ankle area, the POTS, cotton, pylon, and mesoneum. Mesoneum, it involves the proximal fibula, which can damage the common peroneal nerve. And if common peroneal is damaged, it will lead to foot drop. And foot drop, if anyone is having, it leads to the involvement of the sapien, the foot drop, and person has to walk with a high stepping gait. Right? It is leading to high stepping gait. Okay. Now see, this talus bone. Next one is the talus bone. Why is it important, talus? Because of its risk to get into the necrosis. Okay. Three eponyms I want you to remember from talus itself. One is aviator, there is a neck of talus. Shepherd is the posterior part of the talus, and the snowboard is the lateral process of talus. Fine. So these are aviators, shepherd, and the snowboard. Right? Oh, okay. You're right. So these are three eponyms, and very important point about the talus is its tendency to go into necrosis. Okay, its tendency to get into necrosis. The Hawkins sign is what? Hawkins sign is when you see sclerosis at the dome of the talus like this, it is telling you about the retained vascularity of the talus. Talus is still vascular, it's good, right? And Hawkins classification is, it is also done for talus only, along with the fracture, that what all areas are getting displaced. That is what you call as the Hawkins classification. This is about talus. This is about the talus area. So these are from trauma. What I want you to remember, all the points about the trauma, right? Now coming on to the nerves, what all special test I want to remember from the nerve area. See, first of all, in the nerves, I want to remember this classification system, especially the sedans. Please remember that there are three kind of injuries. We have in sedans. In sedans, what do we have? Neuropraxia, exontemesis, and neurotomesis. Neuropraxia, exontemesis, and neurotomesis. So neuropraxia is what? It is the physiological conduction block, right? That is physiological conduction block. What is that? Normal Saturday night palsies which recover on their own. Exontemesis is the injury to the axon plus or minus with or without endoneurium. And neurotomesis means complete transaction of the nerve. It is the complete transaction of the nerve. Okay, so this is complete transaction of the nerve. So here the surgeon has to just improve it. Surgeon has to just repair it. So that is the only way to improvise the nerve. Exontemesis can improve itself. It can recover itself. So if they ask you again in the INICET exam, which grade of the nerve injury has the probability of automatic recovery, this has to happen with exontemesis, right? That has to happen with exontemesis. All right. Then you have the test, the clinical pictures of the median nerve and the ulnar nerve. So please remember, there is a pen test for the median nerve. I'm telling you first. For the median nerve, we have the pen test. Why it is to be done? It is to be done for abductor pollicis brevis like this. Okay, one pen test. Second is OK sign. That is for anterior interosseous nerve, right? Anterior interosseous nerve. Okay, that is for anterior interosseous nerve. Third, third is the pointing index sign for the median nerve. That is a pointing index sign for the median nerve. Fourth, ape thumb for the median nerve. Four for the median nerve. Come on to the ulnar side. Ulnar side, the book test for adductor pollicis. Don't forget these. Adductor pollicis, Froment sign. Then adductor pollicis failure leads to what? Froment sign. So book test and Froment sign. Right? Froment sign is basically the usage of the median nerve, flexing the thumb to hold the object, and ulnar nerve is getting a failure, right? Okay, so these are the tests for the ulnar, and in the ulnar I want you also to remember something called as the ulnar claw, right? Only the ulnar claw, and that is happening all because of the involvement of all the intrinsic muscles except for the lateral two lumbricals and the thenar muscle. So there will only be ulnar claw. So please don't forget these four special tests here. The pen test 1, the OK sign number 2, pointing index number 3, and ape thumb number 4, right? 4 for the median nerve. And for the ulnar nerve, the book test and the failure of it is Froment sign. Then you have the only ulnar claw, right? Now this about the radial nerve. Please don't forget about the presentation when the injury occurs at a different location. Okay. The locations may be variable and they change the presentation of the patient. For example, if there is an injury in the axilla, this is what you're calling as crutch palsy. So every action of the radial nerve will be failing. Every action of the radial nerve will be failing. Second is the spiral groove injury. Spiral groove injury is basically called as the Saturday night palsy. Difference will be in axilla. If the injury is happening, all the action will be lost, absolutely lost. In Saturday night palsy, it is in the spiral groove. So there is a weak extension of elbow, which is possible, right? Weak extension of the elbow is absolutely possible. And the fourth one written over here, the radial head injury, the post-interosseous nerve, remember, in Montegia, right? After that, I want you to remember all the entrapment neuropathies, most importantly, the carpal tunnel, number one, the flexor retinaculum. And the tests are Durkan's, Phalen's, Tinel's, and Tourniquet, the clinical test, right? Second one, the cubital tunnel here, the ulnar nerve. Number three is about the thoracic outlet, the subclavian vessel, the Roos test, Adson test, and Wright test. These three tests. Okay, these are the ones which I want you to remember, and the neck of fibula has been the repeated question. All right, so this is neck of fibula, the common peroneal nerve, which has been asked in all the three exams of the year 2023. Okay, so these are all different. These are all different. Yeah, entrapment areas where different nerves can be involved, and these have been the recent MCQs, so no mistakes here in all of them. Okay, so test for median, radial, ulnar, very important. Entrapment neuropathies, very, very important. And the grading, the classification sentence is very important, right? And Tinel sign, definitely no mistakes in Tinel sign, right? Tinel's has to be okay. Okay, so Tinel's has to be all the time. You have to remember them, and you should know that that is used to assess the recovery of the nerve. So Tinel's is nothing special, but just tapping on the course of the nerve, right? That will be Tinel's. Okay, after this nerve, we have the next topic coming up from the tumors. Now guys, see, this is the tumors which I want you to remember. This one-page image of the tumor is available on all the Telegram group, whether it is DBMCI Premier group or my orthopedic discussion group. So this kind of image you should know, and you should be able to recall everything about the tumors. Okay, everything about the tumors, right? The first one is the location. Second is the nature. Third is always the special feature, what is linked to it. And fourth one is the treatment plan, right? Remember the 4 parameters about the bone tumors. Please remember them. And question, if it is coming, they come from only these 4 points. What is the location linked to it? What is the special feature? What is the nature? And what are the treatment plans? Okay, so now see, when you look at the epiphyseal area, you have got these 2 tumors, GCT and chondroblastomas. And how to make a difference in these 2? GCT will be the tumor of the patients who are coming to you between the age of 20 to 40 years, adults. So bubble, classical things, right? And chondroblastoma has to be the tumor of a child, 10 to 25. That means if in a patient you see a growth plate and epiphyseal lesion, more favors chondroblastoma, right? If you see a lesion at epiphyseal area and it goes towards your skeletally mature patient, then it is favoring giant cell tumor. Then in the metaphyseal area, we have different lesions like NOF. NOF is the most commonest benign malignancy, or you can say lesion only of the bone. It's not a real tumor. NOF. ABC and UBC, how to make a difference? Both are cystic lesions, both are benign. And in UBC, what do we find? In UBC, we can see the fallen leaf sign, or what you call as the fallen fragment sign. Fallen leaf sign or the fallen fragment sign. Okay, and ABC, what do you find? You will find the soap bubble appearance, the septated soap bubble appearance at metaphyseal area, right? Septated soap bubble appearance at the metaphyseal area. And if you see a lesion at the surface of the bone growing away with a stalk or without a stalk, it is most often like favoring osteochondromas, which are again not the real tumors. They grow away from the joint line, and the treatment, if required, is excision, right? Treatment we require is excision. Okay, so treatment required is excision only. Okay, if it is creating some trouble. Then we have the malignant tumor at the metaphyseal area, which is osteosarcoma, right? Codman's triangle, sunburst appearances, they are linked to osteosarcomas. Okay, now when you talk about the diaphyseal area, in the diaphysis we have, okay, in the diaphysis, what do we have? We have this osteoid osteoma, which is the most commonest true tumor, right? This osteoid osteoma is a real malignancy of the bone, true tumor. Why? Because it is coming from the blast only, right? And this blastic lesion, when it turns into the aggression, it is called as osteoblastoma. When this tumor may involve the soft tissues, we are going to call it osteosarcomas, right? So most commonest true tumor of the bone is osteoid osteoma, real tumor, benign tumor I'm saying, right? Fibrous dysplasia is the one which makes the bone fibrotic. The fibrous dysplasia, when the bone is getting abnormal, right? So this creates a very special feature in the proximal femur, and what do we call that? That is called the Shepherd crook deformity. Remember, the proximal femur getting bent like the upper end of a stick like this. This is called Shepherd crook deformity. This is called Shepherd crook deformity. All right. And now when you look at the other tumor where you see multiple layers of the periosteum, parallel to the bone, something like this picture, you know, this is called lamellated appearance or the typical onion peel appearance tumor being Ewing sarcoma, which is the most commonest tumor in the first decade of life, first year to 10th year, it is Ewing sarcoma, right? For the second decade of life, it is osteosarcoma. Okay, this one has to be remembered. 1 to 10 years Ewing's, 11 to 20 years osteosarcoma, the most commonest malignancies of the bone. All right, now these are the, you know, this paper, this kind of sheet, this kind of image sketch is available everywhere. Go through this sketch and your all questions of tumors can be like answered from this single sketch only, right? Now see, next one after the tumors, we have the images of the osteomyelitis, right? Image of osteomyelitis. Now see, if you get an image of osteomyelitis, first of all, in the infections, I want you to remember two most important things. See, okay, now see this. In this, I want you to remember two most important things. What are those? Number one, which is the most sensitive investigation when you're talking about infections? Which is the most sensitive investigations when you're talking about infection? Most sensitive always and always is MRI. Please remember this. Most sensitive is MRI, right? MRI is most sensitive because it shows marrow edema. It shows marrow edema, and it can show marrow edema in the first 24 hours only, right? So MRI stays the most sensitive investigation. When you talk about the most specific investigation, the gold standard, it is your aspiration or the biopsy, which you have to send for culture and sensitivity, right? So this can be, you know, the specific question or the sensitive based question. So whatever is there, you have to answer, you know, in a proper manner. Now please understand, when you are talking about the infections, whether it is TB or the septic arthritis, one very, very important point, septic arthritis most commonly affect the hip and knee, same as the tubercular arthritis, but septic arthritis, this is very important point here, septic arthritis most commonly affect which part of the bone? It affects proximal femur, right? Septic arthritis is going to have the foci most commonly in proximal femur, but when it is about the TB hip, it most commonly involves acetabulum, right? It most commonly involves acetabulum. So this is the difference, proximal femur or acetabulum. All right. Now when you just look at, when you're here, now look at the image of chronic osteomyelitis. When you look at the image of chronic osteomyelitis here, the most important thing you should keep in mind is sequestrum and involucrum. Please don't make any mistakes while you're marking the images there. Sequestrum and involucrum. See, sequestrum has to be this dead piece of the bone. Sequestrum has to be this dead piece of the bone. And if you see white shadows all around, then it has to be involucrum, right? It is involucrum. Okay. Yeah. So involucrum always is a white bone. Involucrum is always the white bone. Yeah. All around the sequestrum area. Okay, it is all around the sequestrum area, and wherever the bone perforates, okay, wherever the bone perforates, it is called as the cloaca. Third entity which is not seen right now, it is called as cloaca. So sequestrum, involucrum and cloaca, these are three things to be seen in a case of chronic osteomyelitis, right? See, when you get an image here, don't get confused between the sequestrum and the involucrum. Sequestrum has to be that piece of the bone, right? Involucrum has to be a new bone all around that dead bone, and that will be called as involucrum, right? In the previous few sessions, we have got one time the image of this one in INICET, and before that it was in AIMS exam. So don't mark anything wrong here. Sequestrum has to be that dead bone with piece, white piece, which is dead. Okay, white is white because in that dead tissue, that part of the bone, the demineralization cannot happen. Demineralization cannot happen, right? The minerals cannot be taken out. All right. Now see, in the cases of chronic osteomyelitis, the two most important points, which is the most commonest complication, right? Which is the most commonest complication to be seen? It is acute exacerbations, right? It is the acute exacerbations. And whenever you're talking about the sinus tract malignancy, it is always and always squamous cell carcinoma, right? It is just the squamous cell carcinoma. All right. Oh, okay. So these are two questions which you should not be marking, wrong when they ask you most commonest complication, acute exacerbations, and the sinus tract malignancy always has to be, okay, it always has to be squamous cell carcinoma. All right. Now see, in the TB, always remember the most commonest pattern of involvement in TB spine. It is always paradiscal. Right? And when you talk about the TB hip, the commonest one, please don't forget these table. Yeah, this table, you don't have to forget. How are different stages of TB here? TB passes through or goes via 4 stages. The first one being synovitis. In the synovitis, it has to be abduction external rotation, apparent lengthening, no specific bony change. Okay, second one, early arthritis, meaning by the apparent shortening now, but only the pressure effect onto the bone, which is called as periarticular osteopenia. Third one is the true shortening, where there is a decrease or loss of the joint space. And fourth one is gross shortening coming to us with the wandering acetabulum. All right, these are 4 most important points. And the fifth one here, it will be fixed flexion deformity of the hip, which is tested by the Thomas test. Fixed flexion deformity of the hip, which is done by or checked by Thomas test. It has been a very important test in the past as well, and they have asked you the sequential arrangement pattern question based on Thomas also. Okay, how the steps of Thomas are. Okay. All right. So this is about the TB hip. So please don't forget the stages: wandering acetabulum, decrease of the joint space, Thomas test, and the fixed flexion deformity of the back. Okay, so this is all in TB. I want you to remember the investigations, their relevance. I want you to remember the image of chronic osteomyelitis and the tuberculosis. Okay, the tuberculosis. All right, so next one, I want you to remember about the test of CDH, right? The DDH. So please remember the very first, when you talk about the CDH or the CTV. Okay, so now when you just talk about the CDH first or the DDH, the very first test to be done is Barlow's. Number 1 test in any newborn baby is Barlow's. Barlow's test is all about dislocating hip, right? It is always about dislocating the hip. Okay, so it is about dislocating. And how to dislocate the hip? You just bring the hip closer and you just give it a gentle push, and once there is a tendency, it is going to dislocate, right? To reduce it, you just have to open it up. And pull it, right? That is called as Ortoloni test. So Barlow's and Ortoloni. This is about reducing, dislocating and reducing. All right. So dislocating test, Barlow's, and Ortoloni was for reducing it. These two. Third, when you compare the position of the knee, the test is called as Ellis or the Galeazzi. Third one is Ellis or Galeazzi. So third test to be done is Ellis test or the Galeazzi sign. When the child is walking, please remember, any child who is walking with a neglected CDH, if it is a unilateral walk, he is going to walk with a Trendelenburg gait, right? And if it is a bilateral neglected CDH, then they walk with a lurching gait. So it is a Trendelenburg gait or lurching gait, depending upon uni or bilateral. If you have to diagnose the patients, it has to be investigation of choice. When they say for screening, when you have to screen, only ultrasound. When you have to plan the management, confirm the diagnosis, everything has to be seen. then it has to be MRI. So ultrasounds and MRI have to be done. Ultrasound and MRI is to be done here. Okay, and for the treatment plan, please remember, till 6 months we can use the braces, we can use the splints called as the Pavlik harness or von Rosen splint. After that, muscles are stronger, so we have to use plasters to make those kind of splintages or supports. So they are called frog leg cast or the bachelor's cast. And after 1.5 years, we have to go for surgery, open reduction only. Right? Then we go for open reduction only. Right? This is CDH. And in CTV, what I want you to remember, the CTV concept here, that how do we treat a patient of CTV and what all are the deformities. So please remember, in CTV, the deformities are cavus, adduction, varus, equinus, inversion, and others too. But these are the basic ones, right? There are others too, but these are the basic ones. So what are the treatment plans here? Treatment plan here, it is by Ponseti. Every line here is a MCQ for you. Ponseti technique, start the treatment as soon as possible. Correct them in the sequence of cave only. If you don't follow cave, there is a possibility of developing rocker bottom foot. Normally, 6 to 7 plasters, change every 5 to 7 days. How to assess the correction? By Pirani scoring. Once the foot is corrected, then Dennis Brown splint. And once the child is walking, then we go for CTV shoes. Right? CTV shoes have some features. Lateral margin is raised to counter the inversion part. Medial margin is straight to counter the adduction part. Heel is not there to counter the equinus part. Right? These are deformities of CTV and their like relevances. So please remember these relevances there. Okay. Then we have from OA and RA, we don't get many questions, but from ankylosing spondylitis, I can tell you, they've asked you the questions multiple number of times. Ankylosing spondylitis. Now, what exactly do we see in AS? Young boy, see, I'll give you a very basic approach. If you find a patient in your exam who is having bilateral, stiffness, bilateral stiffness of both the hands, then we are talking about a case of rheumatoid. If it is knee pain, it has to be OA. If it is about the back pain, young male, morning stiffness, and enthesitis, like tennis elbow, golfer's elbow, Achilles tendinitis, or plantar fasciitis, then we are talking about the cases of the ankylosing spondylitis, like bamboo spine and the dagger sign, right? Okay. All right. So do remember them. Do remember them, the features which are related to the OA, RA, and ankylosing spondylitis. See, OA is going to damage the cartilage. So it involves primarily your knee joint. RA, it primarily damages the synovium, inflammatory things. So that usually damage start from the wrist area. AS has to start from the back area. Okay. So Krishnan is USMLE passed out student. Okay. You have passed out, Krishna. Congratulations if it is so. Okay. Then other than that, I can tell you about all the one-liners, right? One-liners you should know. See, adhesive capsulitis, if the question, patient will have the first trouble in keeping the hand on the lower back, right? That is internal rotation. Painful arc syndrome is when the person is having a difficulty in mobility of the shoulder 60 degrees to 120 degrees. Okay, and the most commonest culprit here is supraspinatus, tendinitis, calcification, and partial tear. Right, supraspinatus, calcification, tendinitis, and partial tear. Then we have the 4 conditions here. Baseball pitcher's elbow, what is that? Medial epicondyle epiphysitis, growth plate getting inflamed. Golfers, medial epicondylitis. Javelin thrower is injury to ligament here, ulnar collateral ligament, and tennis elbow is lateral epicondylitis. Right? Decurvent stenosynovitis is the last condition I want to remember. It is the inflammation of abductor pollicis longus here and extensor pollicis brevis. The clinical test to be done is ICOF or Finkelstein. Yes, Prachi is right. HLA-B27 has a strong association. So, Prachi, you have to diagnose the patient in your exams, in your clinics. So, I told you the brief idea. See, I'll repeat that part. Knee pain, OA. Bilateral involvement of joints, symmetrical one, RA. Back pain, morning stiffness, young boy, AS. First MTP, gout. Sudden effusion of knee, pseudo gout. Without any trauma damage to the joint, neuropathic joint, right? That is a basic approach to any of the joint disorder, right? So guys, this is from the orthopedic point of view. Okay, USMLE third step clear. Very good, Krishna. Congratulations to you. Okay, so guys, this is all from the orthopedics. All the topics of the INICET exam. You can expect that most of your questions or probably all of your questions will be coming from here only, right? So all the notes that you have from orthopedics, from our institute, from wherever you are having that notes, trust that notes, and all the topics which I've told you, these are the must that you should have for your INICET exam, right? There might be some add-ons sometime in the exam. You can never expect that, right? That is INICET exam. But these are the minimum questions that you should know at least. Okay. So if you're not clear about any of the topic that we have discussed, feel free to connect with me and I'll be more than happy to help you out as soon as possible. All right. So that is all from my side. Just drop me a message. If there is any thought you have about the orthopedic troubles you have, just drop me a message and I'll try to revert back as soon as possible. All right. So that is all. Thank you so much, everyone, for being a part of the session. And yeah, everybody has answered most of the questions correctly only. All right. So thank you, everyone.